Good. Thank you.
Okay. All right. Well, thank you. Well, I'm Morgan Hardy. I'm a major in the United States Air Force. I am a staff psychiatrist at an American military base here in the UK at RAF Lakenheath, and I'm also adjunct assistant professor of psychiatry at Uniformed Services University. So I'll be talking today about ketamine in the military, implications for use, and also a bit about my own personal experience. I'll start by saying the views I'll express here are my own, do not represent official policy or position of the United States Department of Defense. Also, I have no conflicts of interest. So so let's start with the scope of the problem. So we know that depression and PTSD are common problems in the military. One study suggested that the prevalence of depression among military members globally was as high as 23%, so quite high. This can lead to a variety of adverse outcomes: premature return from deployment, major disruptions to the military mission, early separation or military retirement, increased risk of substance use disorders, and in worst case scenarios, suicide. We also know that conventional treatments can often take months to achieve full efficacy, things like evidence-based psychotherapies or antidepressant medications. And also there's a high rate of treatment resistance. And the risk of treatment resistance is even higher in combat veterans and those with comorbid depression, PTSD. So ketamine offers a promising option for this difficult to treat patient population. First of all, it has demonstrated efficacy in treatment-resistant depression, PTSD, as Adriana pointed out, suicidal ideation. It's relatively rapid-acting, it's safe, it's cost-effective, minimal equipment and staffing is needed, unlike something like RTMS or ECT. And the best part about this for the military is that it is already readily available in nearly all or all military treatment facilities because of its important use in procedural anesthesia and analgesia. So I'll talk a bit about my personal experience getting involved in ketamine. So I came to this arena not from a research perspective, but more out of a clinical necessity. So as a newly trained psychiatrist, accepting my first operational position here in the UK, at American Air Force Base here, I quickly observed that I was quite limited when it came to treating treatment-resistant depression and treatment-resistant PTSD. We had a limited list of medications that we can obtain through our military pharmacy. We have psychotherapy, and then beyond that, if people are still struggling, we can either hospitalize them in an expensive civilian hospital, or we can send them home. And so I started looking at what other options do we have. I was familiar with ketamine, but really no one was doing this in a large scale in the military at the time. There was no standardized method for this. There were a few Army hospitals that had kind of been doing it more in a research setting, but really no one was doing it. And so together with my colleagues in anesthesia and our pain management clinic, we developed a protocol and we started offering this treatment. And we have the distinction of being the first ketamine clinic in the Air Force to offer this treatment. So patients we have treated include active duty service members, a few retirees who still work on the military base, as well as adult family members. Anyone with the DSM-5 diagnosis of moderate or severe major depressive disorder and possible comorbid PTSD. And also demonstrated treatment resistance. So we've excluded anyone with psychotic symptoms, an active alcohol use disorder, history of illicit substance use disorder, or otherwise medically unstable or pregnant. So for our treatment regimen, we followed the standardly accepted protocol that's been used a lot in the literature, 6 to 8 initial intravenous infusions. We actually do them twice a week for 4 weeks at an initial dose of 0.5 mg per kg over 40 minutes. And then after that initial infusion, induction, We've also offered 1 month maintenance infusions if needed. So we've been able to treat 18 patients thus far. 13 have been active duty, 5 have been civilian, 11 men, 7 women, and vast majority have recurrent major depressive disorder. We did have 1 patient with bipolar depression, and then 10 of those patients have had comorbid PTSD. So our treatment outcomes have actually been quite good. We collect PHQ-9 scores on all our patients, and we had a pretty significant drop in PHQ-9 score with a pretty significant effect size. 25% have experienced full remission of symptoms, and 44% have experienced a clinically significant response. So about in line with clinical trials on this. We also were able to collect some patient perception data on a subset of those patients. When asked about their own assessment of improvement in their symptoms and functional outcomes, most say moderate or significant improvement, and most are very satisfied with the treatment. So next steps at our clinic is we were recently approved to administer intranasal S-ketamine or Spravato. We have not yet started that, but we're building a protocol to do so. We'd also like to pair it with evidence-based trauma psychotherapies for our patients with PTSD, similar to what Adriana was talking about. And then also expanding this option to other bases. So I was able to give a longer version of this talk to a military psychiatry organization last year, and had a number of people reaching out to me. And so I've been able to consult with psychiatrists at other US bases, mostly in the United States, that are seeking to implement ketamine programs at their own base and building protocols for that. So my hope is that this can become a much more standardized treatment option for the military. I want to talk a bit about making the case for wider adoption in the armed forces. So I really view this as a treatment that can improve care access for treatment-resistant depression and PTSD, and can prevent potentially more costly alternatives such as medical reassignment, evacuations from their base to get more extensive treatment, and it can also allow us to provide treatment closer to the member's assigned unit. And potentially, and we need to study this more, can it reduce suicide risk for our active duty military members, as you all know is a major problem. I want to close just by giving a brief shout out to work that's being done in Ukraine. So this was an article published in The Economist earlier this year, chronicling the work of a psychiatrist in Ukraine, Vladislav Machinesky, who has been providing ketamine treatment for active duty Ukrainian military members and being able to help them return to the fight. And so I suspect that ketamine is going to be more and more commonly used in militaries around the world as we go forward. With that, I'll close.
Thank you for the talk. So it looks like the indications you're focused on primarily are treatment resistance in depression. Are you also extending it to acutely suicidal active duty personnel? And the second question is regarding route of administration. I'm aware of a clinical trial that's about to start, funded by the DoD, the Strong Star Consortium. Mm-hmm. They're looking at intramuscular 1 milligram per kilogram application. Have you also considered intramuscular, or are you pretty much looking at just IV?
Sure. We have. There's actually a couple of my colleagues that I mentioned that I'm helping consult with. They're looking at intramuscular as well, just because it would be easier to administer. I'm a little bit hesitant just because we don't kind of fully understand the bioavailability. It's a little bit easier to predict response with intravenous, and I think intramuscular has just been less studied. But yeah, totally an option that would be easier to administer.
Hello.
Hi.
Why move to Spravato next if it's not, if it's more expensive and not as effective, and even in some trials did not help with suicide ideation?
Yeah, yeah, just to clarify, so we're not going to stop doing intravenous, but we're also being able to offer Spravato, and so the rationale there is just that it's a bit, ketamine, as you may know, is becoming more and more difficult to obtain, so it would be a nice alternative if we ever like ran out of ketamine for a certain period of time, but also I think it could be just an additional alternative for patients who are hesitant to receive the intravenous treatment. It's a little more accessible, easier to administer in our clinic, things like that. It's expensive, yeah. The military is at least footing the bill for now. So yeah, but it is expensive, that is true.
Thanks. Well, we look forward to hearing a bit more about your experience.
Yes, thank you.
So thank you very much.